the co-chair of the FES task force, Dr. Jeffrey Marks. I think most of you probably know Dr. Marks. He's from Case Western in Cleveland, Ohio. He was actually my mentor in fellowship. He is a master surgeon and surgical endoscopist, and he's going to tell us about the details of the FES program.
Thanks, Brian. Can we clap for Brian a little bit? He forgot to give us that opportunity. Brian, thank you. So my talk today is to talk about what FES is and what it entails, what are the components of it, and at the end we're going to get a chance to kind of answer some questions because it's not smoke and mirrors anymore. There is obviously a product. It is a thing that you're going to be using. My expectations are that we're just like FLS, we're going to be using it. I was asked a couple times already, is it FES? It's not a fancy hat. What is FES? It is the letters. It's not a hat. And it is a multiple component exam here. So these are my disclosures. None of them obviously have impacted any of my work with this. And one thing I want to talk about is this product, this whole project has been supported solely by SAGES. All right? There's been no industry at all input whatsoever into this project. There's a lot of industry demand. There's been a lot of industry interest. And at the end, we'll talk a little bit about where things are going in terms of, I guess, a little bit of a business plan. But right now, we're going to talk just about the product itself. There are 4 key components, and Brian alluded to all of them already. And I think, you know, again, it's easy to understand that they all have different impact on both training and testing. The web-based didactic program obviously is necessary for the residents and the GI fellows to get a chance to learn, obviously, the cognitive part of endoscopy. It's not just a technical procedure. The high-stakes written exam, as well as the validated hands-on testing tool, and then finally the global assessment tool, which copied the GOALS, which was the global assessment tool for laparoscopy created by Dr. Fried and his group. So this is one of the cover pages for the FES exam, and if you had a chance to stop by the FLS booth over the last couple of days, you saw it in a more interactive way. We weren't able to get internet here in the podium, but basically you'll see that it basically is a wonderfully interactive way of looking, obviously with big endoscopic pictures as well as well-written titles and font. We had to increase the font. I kept on pushing Lisa and Carla to let me increase the font as I got older. I couldn't see it and wanted to make the pictures a little bit smaller, but you'll find that it's a very easy way of getting things along with the drop-down program. The hardest part about all of this was getting the images, okay? And SAGES, as a video-based organization, was very helpful, and we were able to pull lots from our enduring library, but we wanted to have as much up-to-date stuff as well, and so we were scouring through our own libraries, but doing a lot of it as we were working over the 3 years, pulling pictures out of day-to-day cases and getting some up-to-date images, I think was the most important thing to understand about all this. So let's go to the next component, okay? After the cognitive part on the web, all right, which I said is going to be a key component of the overall FES project, is the high-stakes written exam. And it is very, very interesting to realize that you will have gone through your entire life, if you don't do FES, never having taken a validated test, all right? And this is something that Melina and I were talking about, at least in the United States. A driving test is not a validated test. A ABSITE exam is not a validated test. Your certifying and qualifying tests that allow you to be a surgeon, okay, are not validated exams to the high stakes level that we've gone with FES following an FLS pathway. So basically, as Brian had mentioned, Criterion is a company that has done thousands of validated exams. Surprisingly, not many of them in the medical fields, but some of them as well. And they basically put us through this arduous process of weighting the objectives of endoscopy. Is knowing the endoscopic tools more important than knowing how to push the buttons? And is knowing what a polyp looks like more important than knowing what a stricture looks like? And again, this was utilized with our GI components because one of the things, and if there are gastroenterologists in the room, you know, at the end when we talk, maybe we'll ask you about that, but the hard part is, what is the acceptance rate going to be when we put this project out there? I mean, are the GI people going to push back a little bit, and we'll talk about that during our discussion, or are they going to be accepting of a obviously high stakes exam that's validated looking at proficiency? So we wrote 250 questions. For those of you that have written any questions, let's say for ABSITE or any of the tests that we take along the way, writing this kind of thing is very challenging. And what we did is we took about a dozen people and locked them in a hotel conference room for several days on multiple occasions. Lisa and then Carla would basically lock the door, prevent us from getting out, and we would basically write all these exams, questions. And then what we had to do is get 2 75-question tests. All right? So the goal when FES comes out, when you have the exam and your residents are taking it, there will be 2 75-question tests. But out of those 250 questions, we had to make sure that we had enough questions. And I'll go over the validation process in the next talk. And the final thing, again, is the beta testing, which is in process. And so, again, this has been a key component of making sure that what we wanted to test actually is measuring endoscopic skills. The validated hands-on testing tool, Melina's going to talk to us a little bit more about the actual validation process for this. But basically what we did is we took endoscopy, both upper and lower endoscopy, and said, what are the components of being able to do a proficient level of endoscopy, and basically looked at the skill set. So similar to FLS, cutting a piece of paper is obviously not a key component of doing, let's say, a lap chole, but putting those combination of skills of peg transfer, of cutting paper, of going ahead and doing suturing, are all obviously isolated key components of being a skilled fundamental laparoscopic physician. This is testing on the virtual reality simulator. I want everyone to understand that not all of you are going to have to go out and buy a Symbionics Mentor 2, and I'm sure the company would love it if you did, but the goals are that we have to validate the test on something that we can objectively get the information back from. And you saw the creamer and the muffin and the straws, and I was completely convinced that's what we needed to use in the beginning. We spent a lot of time going back and forth from a non-VR to a VR system, and we basically, with Jerry's, I think, insistence, the mistakes, so to speak, of FLS are having to measure the paper, of having to use proctoring, and we wanted to get away from that a little bit and basically take advantage of the simulation out there. And Brian may not have mentioned, we put out RFPs in terms of looking at the other simulation companies. It wasn't as if we just selected Symbionics right off the shelf. Training for this program can be done on anything, and we'll talk about that as well during our discussion. You can train on any simulator you want, whether it be a virtual, non-virtual type of process, and eventually over time, just like FLS has gone through, I'm sure people, you in the audience, will go through investigations, finding out what proficiency levels are necessary, just like Danny Scott has done for the FLS program, knowing what the proficiency times are, so we'll know what our residents will need to pass the test. And finally, for the hands-on test, it's gone through the beta testing, and we are still in process of revisiting and revisiting, making sure that we have the high-stakes exam that is validated for this process. We talked about the deconstruction. These are the 5 components that we decided were important: navigation, loop reduction, retroflexion, and traversing through a sphincter, or a pylorus, let's say, mucosal evaluation, and then finally targeting. And the way this looks, and I'll talk a little bit through this video, this is actually the updated modules put together, kind of strung together. There is a 10-minute time limit for each of these, with a 5-minute practice in the beginning. So the first one here, as I said, is a navigation system, and there are instructions that will be given as well as a slight scripting. You'll advance an endoscope. Obviously, it looks as a colon would. There is some kind of, recognition of this being in a non, so to speak, kind of game environment. And basically the goal is to take the shadow, put the chest piece inside the shadow, and eventually the chest piece will melt away, and you'll progress along to the next one. Now, the skills that are required to do this are obviously things that require tip deflection, torquing, preventing the scope from obviously hitting against the wall. And so there are multiple metrics that we're measuring along the way here, in addition to time, because time cannot be the only metric when it comes to being proficient with any skill set, whether it be driving a car or doing endoscopy or doing laparoscopy. And you can see that we move along here, and it's very similar. This is a different module. For those of you that do have a Mentor 2 or even a Mentor 1, this is a brand new module in terms of a colon. We basically reconstructed it right from the start, and we go ahead and traverse along here. One of the things that we wanted to do is to make sure that people that did endoscopy, we didn't want to exclude people that never did a colonoscopy, or people that, like a colorectal doctors, are they going to be able to do an upper GI thing? And so that's why when we deconstructed these skills, we felt that they were important for any type of endoscopic exam. So the next task, after you've completed that first one, as I said, there's a 10-minute time limit for each of these, okay? And here's our next exam coming up, a little instruction in the beginning. And this will be what is called loop reduction. Now, we are trying not to label them because we don't want to be teaching, so to speak. We want to be testing along the way. You can do as much training as you want, but basically the goals of this one, and this has been the hardest one to put together in a VR system, is that basically you get to a certain point, you'll obviously get paradoxical motion as you would if you were trying to traverse across a sigmoid colon, and you have to use, obviously, levels of expertise or skills to allow us to allow advancement in terms of suctioning, torquing the scope, and reducing the loop. As the resident or the participant moves along, there are 3 different randomized loops that they will have to traverse, and once they get to the end, we'll have measured the metrics again of velocity or speed and time, as well as torquing of the scope and the use of those techniques to traverse across here. The third component is an why did I get to this one here? We skipped the third. These are out of order. We kept them all in the lower. At one point in time, we were going to try to do all the lowers at first. So now what we're going to go ahead and do is go ahead, and this is still a second loop. I apologize. They put all 3 loops here in together. The 3 loops are different, which is kind of nice, so that they have to go ahead and traverse through these. These are time-related, and there is a time cutoff, such that if you are not able to make it to the end, you obviously have a penalty. And that's the hard part, is trying to weight the different penalties, and that's what we're doing now in terms of the validation. So here is the next testing of going ahead and doing an evaluation in the upper GI tract. The hard part about this one is basically getting the colorectal doctors to buy into this, all right? If you've never done an upper endoscopy because you're a colorectal surgeon, what is the advantage of this? Well, retroflexion is one of the testing tools in this exam, and retroflexion is a key component of colonoscopy, as well as traversing possibly across the sphincter or the ileocecal valve. The pylorus here, as you can imagine, functions as any type of sphincter. It was going to be the creamer in the non-VR system, getting into the creamer, but we went, as I said, with the VR system. Once you traverse across into the proximal duodenum, you'll pass a target and come to the end point, and you can see here the targets will melt away once they've been held in the visualized viewpoint of the endoscopist. Other components of endoscopy, obviously, are use of torquing, insufflation, suctioning, and again, these are parameters and metrics that will be measured along the way and help to differentiate from our expert, from our novice, and our proficient endoscopist. Here, as we retroflex, we can see a target up on the cardia, and the goal is to make sure we've done a complete endoscopic exam of the upper GI tract. The final 2 tasks here are mucosal evaluation, which again is a key component of any diagnostic endoscopic exam. It is basically knowing what we're looking for and how to do that. And that requires, obviously, the technical ability to deflect the scope, as well as to identify and to insufflate along the way. So this one starts by advancing the scope all the way to the, so to speak, cecum, and the scope is withdrawn. Targets are seen along the way, and they melt away once they are kept in the view for the 1 second time period. Obviously, the use of suction, insufflation, and washing the lens are key components, as well as deflection of the endoscope. One of the issues with this one is that if we go just based on time, someone can pull the scope back, I'm sure, in 25, 30 seconds, but they may miss a lot of the mucosal evaluation. So we need to weight things appropriately in terms of, the mucosal evaluation versus time. And again, each of these different metrics will be weighted to allow creation of a passing grade. Now, you have to understand, for all these tests, there is no passing grade during the beta testing. The final exam here is a targeting. Imagine if you have to take a biopsy of something, or you want to go ahead and do a polypectomy. A key component is obviously managing the endoscope with 2 hands. There are targets, obviously, in our view here, and the goal is to pass a biopsy forceps. Here it's a targeting spear through the green SAGES logo. You'll see it in a second here, okay? If you don't hit the SAGES logo, we make a mistake or an error, and the target will go from red to purple. What's that? Yeah. And it melts away. The biopsy forceps, again, the goal of all of the FES thing, being on a VR system, is to not require an assistant. So basically, there's no opening and closing of a biopsy forceps. Initially, we thought maybe taking a biopsy would be a valuable assessment tool, but what we wanted to do is make sure that it would not require proctoring in terms of having a person to assist. So you can see when we don't hit the appropriate part of the SAGES logo, the target gives us an error report, and these again will be measured. Go ahead, go and touch it. Just to let you know that the person doing the endoscopy right here is from the company, okay? It is not one of the skilled endoscopists that had put this together, all right? Not that they're not great endoscopists by now. And then we complete the course. So again, these are 10-minute tools. The test probably can be finished in about 45 to 50 minutes total. And that was one of the other things we wanted to make sure is that we were able to complete this without obviously making it too much of a challenge to get it done. Now, Brian alluded initially to the assessment tool, and this is based on the goals, the Global Overall Assessment Tool of Laparoscopic Surgery. So we created one called Gauges. Again, the future would be to obviously correlate Gauges scores with proficiency in passing FES. And again, comparing it to things that GI doctors have reported routinely as levels of competency without any validation. Things like time, polyp to the cecum, polyp detection, cecal intubation rates. Again, all of these measurement tools that people are reporting, again, have unfortunately been non-validated. One final thing I want to talk about is what FES is not meant to be. One of the things when we first started creating this project was that people came up to me afterwards, not residents, not educators, but people out in the community, and they were very fearful of this project, okay, that this was not the right way to go, that we were creating something that would make it more challenging, more hoops to get through when it comes to being able to do things when hospital privileging already was a challenge for many surgeons out there trying to do endoscopy. FES is not meant or will be meant to be a credentialing or a privileging tool. I want people to understand that and make sure they convey that to people that do ask them that. And FES will never replace clinical experience, okay, or cognitive experience gained by doing a residency, okay, or a fellowship. What it will do is augment that, okay, and I think the word to understand is that there is definitely a training component to doing this. I have no doubt that if you go through all of the didactics on the web and you do the FES training modules on the simulator, that you will become a better endoscopist. But again, it is not meant to replace routine clinical experience. So basically, in conclusion, FES will be and is the very first validated assessment tool. And you can tell your GI doctors when you go home, hey, I know how I'm going to assess my residents, okay, when it comes to endoscopic skills. What are you going to do, okay? And the next thing is, in terms of when it's going to be rolling out. We use the word rollout because it is a rolling out. We want people to see this, as Brian alluded to, the word transparent is vital, and I'm wonderfully glad to see as many people here in the audience. I was expecting maybe just Dr. Freed and Melina and myself to be here on a sunny Saturday afternoon, but I can understand the dedication you all have to education. And the American Board of Surgery has really been waiting for this. They've been kind of breathing down. Dr. Beisky's been reporting to us. They're really waiting. They want an assessment tool, and they're expecting to fit this into their whole overall system in terms of maintenance of not maintenance of certification, but evaluation of proficiency. And the goal, again, is for the GI doctors. Where is this going to fit in? Well, ASGE has been involved since the start, okay? Brian and I were both on the training committee for ASGE. We are still in communication with them. I will admit the leadership right now in that organization is not very positive towards either surgical education or towards simulation, okay? There's a lot of negativity about endoscopic simulation when it comes to GI people. But again, this simulation is not for training. It's not to replace clinical assessment. It's obviously for our testing and to allow people to become a better proficient individual. So I think, you know, with that being said, there are going to be a lot of questions. There is going to be a lot of pushback, and I think that's to be expected. And we're going to do our best possible to have the best product out there so that we can obviously stand up forward and say, we have a validated exam. Thank you very much. I'm not going anywhere because unfortunately Dr. Poulos had to step away. His wife is about to deliver their baby, and we thought it would be best if he was at home when she was doing that. But this is based on, for those of you who know Ben is an assistant professor of surgery at Vanderbilt University, one of my former fellows as well, and obviously a very skilled endoscopic surgeon, and so he deserves full credit. Even though I put the case logo on this, I consider him still an old fellow of case surgery, so I probably would have made him do it anyways. Again, my disclosures haven't changed at all. So we're going to talk about the validation, okay, of the the written study, and then Dr. Vasilou will come up and talk about the validation of the hands-on tool. And the goal of it is to make it reliable, okay? So that when we did it again and again and again, it gives us the same answer. Is it fair, okay? You know, is it something that's also going to be useful? And I think that's important. So the cognitive exam, again, is assessing several things. It's assessing basically our fundamental knowledge, okay? It's assessing basically the clinician's ability to provide adjunctive diagnostic and therapeutic measures, so that if we ask someone if there is a bleed in the duodenum at an ulcer, what would you like to use? What are the ways of managing this problem? What if you have one in the cecum? How would that be different? So again, it covers the entire GI tract as a cognitive evaluation. So this was quite an arduous task, and Brian went through a lot of this, you know, earlier. But basically, you know, what it came down to is there are at least 9 components here, and to me it seemed like there were at least 50. So when I saw this slide from Ben, I mean, to me it seemed, but basically our first thing we had to find out was who should be certified. What is a proficient endoscopist? And I think you need to understand, this is not someone that's done 5,000 endoscopies. We're not looking for expertise. What we have described as the minimum level of proficiency is someone that is in your program that has completed an endoscopic rotation. So this is a PGY 2, 3, 4, whatever it is, that has completed their GI rotation, had their 6, 8 weeks, whatever it is, been in the GI lab, gone through whatever testing it is in terms of training and such, or a GI fellow at the completion of their first year. And that was our aim with this cognitive test. What would they be required to do? So we had to define the test. I'm sorry, let me go back. We had to define the test, define the domain, who was going to be tested. And we had residents with us in the beginning. I had my fellow and a second, third year resident with us while we were going through this, because a lot of us maybe were too gray to remember what it was that we knew 25, 30 years ago. And we wanted to make sure that we were accurate with this. We went ahead, created our test items in terms of writing these things. And again, that was, again, a very arduous task. And then we had to review the test items over and over again to make sure that, one, we weren't duplicating our test questions, that we weren't teaching people during the test questions. If you had multiple test questions on the same topic, could you be teaching them the answers? And we wanted to make sure that that wasn't the process there. And then finally, we have to evaluate the item performance. How well does that question perform? And that's where the beta testing is going through right now. And finally, we have to implement a passing score, okay, or the test maintenance. You know, what is the standard, okay? When people are beta testing, and this was the hard part, you know, most surgical residents, GI fellows, surgeons as well, and gastroenterologists all want to know, well, did I pass? And it's like, I don't know, all right? There is no passing score, all right? We haven't created that. As competitive people that we are, we wanted to know how well the questions differentiated people along the way. So what are the domains? So basically, there were initially, as Brian said, for the web-based part, there were 7 chapters that we wrote, okay, that have been broken down to about 10 to 12 modules on the web-based platform. But then what we did is we looked at the different test domains. What kind of questions do we want to write? And so we did, you know, let me go back, I am sorry. We went back and went ahead and differentiated things such as the endoscope, setting up the endoscope, patient preparation, anesthesia, all the components of doing an endoscopy, whether it be an upper or lower endoscopy, as well as the endoscopic therapies. We tried not to make this a test of pathology, all right? So there really is no actual testing of looking at histologic slides, but there is obviously pictures, okay, to differentiate. There are obviously questions about setting up and troubleshooting when it comes to endoscopic therapy. So eventually we create 2 exams, all right? Because obviously if you fail test A, you don't want to go take test A again, all right? You'll get test B the second time. And it's important for us to have 2 completely separate tests that obviously function similarly. And when we look at the validation process so far, you'll see that they're working pretty well. The testing itself for the beta testing is 120 questions. So basically, we'll evaluate each of those items. We'll create equivalent forms. I'm sorry, I already said that between the 2 tests. And then eventually, once we get the feedback back from how people performed, we set the standard. The beta test population, again, was a wide range of people, all right? We needed novices, we needed proficient, and we needed experts. And we had to know that it all separated out as best as possible. So we got residents to do this, obviously, in training. We got GI fellows. We got gastroenterologists and surgeons, as well as surgical fellows. And that was what was important, is that we didn't weight it too heavily one way or the other. When we looked at our beta test classification, we had to change things a little bit along the way, because the way people were enrolling themselves as a fellow or a resident. But our goal at the end here is to separate these out. And as I said before, a novice is someone before an endoscopic rotation. And basically you could put PGY 4 and 5 in here as well. Anyone that has not had an endoscopic rotation, experience in the GI lab, experience with obviously cognitive education is someone that is a novice. A proficient person could be a PGY1, I would say, if they were able to have said that they've gone through obviously their endoscopic or GI program or a GI fellow at the end of the year. Experts again included GI fellows beyond that first year, as well as attendings and gastroenterologists. So we looked at the 2 test exams during the validation process. We have about 30 more people that have gone through the testing here over the last 3 days. We are up to about 160 or 260 so far. We're closing in. We need about 100 more. So again, anything you can do to help us with that is wonderful. Hopefully within about a month we'll have that completed. Basically the exam length, as I said, is 120 questions. Takes about an hour to an hour and a half. And along the way we are asking for comments, which is important. How does this question apply to you? And so we're getting a lot of feedback from residents as well as attendings. This question's too hard, this question's too easy, and we're going ahead and obviously and weight that and see what's important in terms of manage this. The mean time on the test is similar between the 2 studies, and again, the mean number of getting correct is also quite similar without any difference. Overall, the frequency distribution of the 2 exams is very important. We don't want to have one of the beta testing tests be too easy or too hard, so that basically when you look at the time and the exam score, excuse me, the frequency and the exam score, they're pretty similar. There are a couple spikes here on Form A, but the company tells us that's not a problem. That shouldn't be an issue, and it's very common to see a couple people outperform the exam. In terms of the pass rates, again, it's not as if there's a passing score, but the goal is to see that the curves are similar in terms of basically exam score and the percent of people scoring that way, all right? So again, you can see here that we're pretty equivalent between these 2, but what you want to see also is that time distribution also being equal, and more importantly, is there a difference between the different novice, expert, and proficient groups. And you do see that if you look at the median numbers here, obviously the experts group are obviously taking a little bit less time. The hard part about time when it comes to beta testing is that an attending may take longer because they're writing in more stuff in terms of comments, whereas a resident may answer the question and then move on to the next question because they want to finish the test. So time in and of itself isn't a vital part of validation, but it is something we want to make sure that we're not doing one test that takes twice as long as the other test. This is the most important part so far, okay? And what we're finding is that you can see that there is a difference, okay, from our novice to proficient to expert groups, okay? And what we'll have to do eventually, once we've completed the last 100, 110 exams, is we will find that passing score, okay? Where is the proficient person going to be on the testing score out of those 75 questions? And I think that's the most important part of this, is there is going to be a standard of which someone that gets above that is considered the minimally level of proficiency. So the next steps, again, is to complete the beta testing, which, as I said, will hopefully be completed within the next month or so, set the standard goal or the passing rate score, and then finally, we have one more retreat to do, okay? And you saw the retreat in Montreal where we're sitting around the cups and the creamers and all that kind of stuff. We have to go through every question again, all right? And again, arduous task as it is to write the questions, it'll be just as arduous to go over them. We try not to take it personal when the group of 12 people, like, say, that question is terrible, this question is good, because it is listed who had written the question from the beginning. And we want to thank our criterion people, okay, Barbara and Stephen, who have helped us along the way with this. So overall, I think what's important to understand is that when this test is ready to go, you get your voucher, okay, if you take the beta test. And what that means basically is if you have helped us produce this exam, I think it's very exciting. I mean, to get a chance to see something before it's ready to, it's like driving that car before it's really ready for someone else to buy it, okay? You've been able to kind of run through it, run around the track a little bit, get a chance to see it before anyone else does. But the other thing that will happen is when this becomes mandated, which I'm not 100%, but 99% convinced the American Board is going to do, having that voucher will allow you to get the test taken over again for free. Now, you have to take the test again, because the test that was taken during the beta test is not the final exam. So you will have to take a written exam again. You will have to take the hands-on exam again. But again, it is a very important part of making a validated tool. Thank you very much. All right, you don't have to listen to anymore because we get to listen to Dr. Vassler now. Melina, where are you? There you are. Okay, I want to introduce Dr. Vassler. Now, Melina has been our voice of reason for the last several years.